Terrific. All right, well, thanks everybody for joining in. Really appreciate everybody coming in, and similar to our previous sessions, would love for this to be a discussion-based presentation rather than a lecture. So please feel free to keep your microphones muted, except for when you want to participate in the conversation, then please go ahead and unmute them and then join in on the discussion. If you prefer to do this just over chat and you want to type things, then that's totally fine as well too. I'll try to pay attention to the chat and we can continue that conversation as we go forward. All right, so we'll get started. So today I'm going to be discussing, I guess, mostly through these two articles, but I wanted to take a bit of a dive into feline kidney ultrasound, kind of using this article that's currently in early view in JVIM, the relationship between ultrasound finding and iris stages in cats with CKD, as a way just to talk about some ultrasonographic findings that have been reported and how we can actually evaluate cat kidneys. I'm going to also talk a little bit in more detail about this paper by Lamb and colleagues that discussed ultrasound findings in cats with and without azotemia, and I'm going to reference a bunch of stuff along the way. But these are the two articles that we're really going to spend the bulk of the time actually critiquing. But I really just wanted to start with what we know about cat ultrasound findings, and as well as maybe some preconceived notions that might not always be correct, and even anatomy that I always are running into incorrect descriptions of cat kidneys on ultrasound as well too. So let's get started. This was the very first mention of feline kidney ultrasound that I could find in a peer-reviewed paper. It's from JAVMA back in March of 1980. And this isn't specific for the kidneys, but they talk about kidneys on ultrasound. And so this is now, 40 years ago, but it is remarkable to see where ultrasound has come in those last 40 years. So these are the images that are produced in that manuscript. And I frankly can't really see anything that I can remotely really identify to be kidneys. These M's that are on the screen are nodules of neoplastic tissue that they've identified, which is kind of just mind-blowing to me that that's what they can see and that they can really see much of anything. But this was that first mention of those ultrasound findings. I love the grid in the background that you're getting here. It's remarkable. It's just so impressive on what we actually do and what we can see now, and what was initially thought of as being, a new test that opened up doors in terms of how we can diagnose things. So that was the first mention, and I could have missed some publications, so I apologize if I did. The next ones were really back in 1987, another two articles that came out looking specifically at kidney ultrasound in cats. I think these were both from the same issue of JAVMA from 1987, and here they talk about the ultrasonographic appearance, and certainly we have better resolution now in those 7 years, but this is the appearance of a clinically normal feline kidney, where to me, when I looked at these images, it kind of looks like one of these raisin kidneys that you see in cats that either have significant CKD. Maybe this kidney had chronic long-standing obstruction or something like that, but it's this little raisin in their abdomen that probably has about 2.5 nephrons left, and sometimes you need those 2.5 nephrons, and you're going to rely on them to carry things along when the other kidney is not working. But this was our normal feline kidney back in 1987. So pretty amazing. And then the last image I wanted to bring up was again from JAVMA in 1987, where they talked about looking at the anatomy of the feline kidney and what could be seen on ultrasound. Pretty short manuscript. They didn't actually have any ultrasound images. They had some computer-generated graphics, which I love, because this is the image that they brought up to describe the kidney, cortex, medulla, and the diverticuli, which is just amazing. I mean, this is going back, I feel like, to Pong type graphics. And they're just trying to tell you, what anatomy you can actually see with the ultrasound, which I think, little trip down memory lane, but I think it's illustrative of what we're actually doing and how far things have come. Certainly, we get much better images when we're doing ultrasound now, and we can really gain the ability to learn a lot about the kidneys that we didn't have back when the technology was at these early points. I will say, full disclosure, that I do not do ultrasounds. I will frequently do just bedside scans on my patients, looking at their kidneys, looking at their urinary tract with our bedside ultrasound. I'm always then sending them up to our radiologists who are using the really good ultrasound equipment, and they've been properly trained. So I'm not the one who's making the final call on diagnoses via ultrasound. I know a lot of internists, many of the people that are on rounds today likely could be the ones who are. So hopefully you'll have some of your experiences that you want to share and discuss as part of the rounds going forward. So just to make sure that we're all on the same page, in the upper left here, this is what we have for the canine and feline kidney, is considered a unilobar lobal or a unipyramidal kidney, that there's just a single renal pyramid, a single renal lobe that's present that connects to the pelvis. That's different than in the upper right. This is a bovine kidney, where it is a multi-pyramidal kidney, where basically each pyramid forms its own separate lobe, and it connects to the collecting system independently. And then down here on the bottom, this is actually an image of a kid kidney, but this is more what is seen in people. And in people, we have a multi-pyramidal kidney, and we'll have each renal pyramid that's connected, and there's a calyx that runs in between. And so we have these calyces that are present. And this is something that we will frequently see on ultrasound reports and even fluoroscopy reports, interventional procedures, where they talk about the calyces of dogs and cats. Dogs and cats have just one calyx, and their renal calyx is basically their renal crest. It's their pelvis. So dogs and cats do not have more than one calyx. They don't have calyces, they just have one. And an anatomical photograph of a kidney from a cat shows that we have just the renal pelvis that's there. This is a drawing that I thought was just beautiful. It comes from a human physician back in 1928, and describing the simple unipyramidal kidney of a rabbit or a cat. I don't know if they just forgot which one they were drawing, but it's a beautiful drawing, and it actually looks much like what we see in anatomy. So we have the cortex, we have the medulla, and we have the pelvis. We do not have calyces. The normal description of the kidney has been described. This is images from the ultrasound textbook, and I thought it just very nicely displayed everything. So we have the cortex, which is more hyperechoic than the medulla. We have the renal crest, which is the pelvis right there in the center. We also have these hyperechoic bands that are extending from the cortex that are heading down towards the pelvis, and those are the diverticuli. And I think I talk about that a little bit more in just a slide or two. This is an ultrasound image obtained here at our hospital just, I think, last week, of a maybe 11-month-old cat, normal kidney function. And this is a little bit of an oblique angle, but we can see hypoechoic medulla, the diverticuli, hyperechoic cortex. It's a normal kidney. This cat has normal kidney function. So if we look at that and we look at the anatomy, just so that we're all on the same page, what frequently gets misrepresented as having the kidney having calyces is the fact that we have the hypoechoic medulla between the diverticuli. And so the diverticuli are the hyperechoic strands coming down from the cortex through the medulla, which gives the appearance of there being calyces, but that is not true. These diverticuli are extensions of the renal cortex into the renal pelvis, into the renal medulla. It often contains the interlobar arteries, interlobar veins, and another name for this is the renal columns of Bertolini or Bertalin. I forget the human person's name. That they're also called, and you can see that on this kind of old micrograph of a dissected kidney that's there. So Ewan had brought up a question: is there a pathologic term for multiple diverticuli formed by hydronephrosis, or is it just a diverticulum? So one of the things that I look for, and I'll actually get to this in just a couple slides, is when these diverticuli become blunted and they become a bit retracted, to me is very suspicious for an obstructive process, and we'll show that in just a few slides. I don't know the exact term. In people, they talk about them becoming hypertrophied, but I think it's a different process in people because remember, they have a multi-pyramidal kidney where our dogs and cats are having a unipyramidal kidney. So I probably wouldn't follow the human terms because it's probably not anatomically correct. What's been described as being normal for cats, their kidney echogenicity should be isoechoic to hyperechoic to the liver, somewhere between about 3 to 4.5 centimeters. And the renal pelvic diameter should typically be non-existent, but one study did find that a pelvis could be up to about 3 millimeters in some what were considered to be normal cats. And we really don't expect to see any ureteral dilation in normal cats. And that's been pretty consistent in the publications that have been submitted so far. So I'm sorry I don't have the references on this slide, but this is actually me going through the various literature that's looked at the normal cats with CKD, those publications looking at ureteral obstruction, which includes pulling the data from the stent, the subs manuscripts, the circumcable ureter paper, it all is included there in the ureteral obstruction. And then what we know a little bit less about is pyelonephritis, but it just gives an idea of what's been reported. This is the median as well as the range of pelvic diameter. So normal, again, you really shouldn't see much pelvic dilation in normal cats, and really no, we shouldn't expect any cats really to have proximal ureteral dilation. CKD has been reported to have up to about a 7 millimeter dilation, but on average, it's only about 1 millimeter, 1.5 millimeters or so, and pretty uncommon that there's going to be proximal ureteral dilation, and we're going to discuss that a little bit more. Ureteral obstruction tends to be the most pronounced. You can have up to 4 centimeters of renal pelvic width, and the majority of these cats are going to have proximal ureteral dilation. And the only other thing that really is on the list when you have significant dilation and proximal ureteral dilation is going to be pyelo, but there is a decent amount of overlap between ureteral obstruction and pyelo, and I would even argue, especially when you're just talking about the renal pelvis, with cats with CKD as well too. So this is from a paper back in 2011 that looked at various conditions and the renal pelvic width that was observed, and they identified anything over 12.5 millimeters was only consistent both in dogs and cats with an obstructive process. But you can see when you're less than 12, there's really a lot of overlap between pyelo, CKD, and obstruction. So it's when it's less than that that it can become really challenging to make that call, whether this is a patient who might have an obstructive process that's there. And what happens when we see a kidney that looks like this? And this is where, as I was responding to Ewan's question, this is where we have pyeloctasia, that there is a widened renal pelvis, but also the diverticuli are blunted. We can see that everything's kind of retracted backwards. So is this just a kidney that has CKD, or does it have obstruction? Does this kidney have CKD? Does it just have obstruction? This has a much smaller renal pelvis. I think this was actually only about 3.5 millimeters. This pelvis, I think, was estimated to be probably about 8 millimeters or so, at least, maybe a little bit bigger. So are both these kidneys obstructed? Is this just what we see in chronic kidney disease? And I believe this was an abstract that was presented at Veery's that reported a third of cats that were obstructed had a renal pelvis that was less than 4 millimeters. And I think our classic idea of the cat with a ureteral obstruction, of having the big pelvis, the huge ureter, the stone that's sitting there, is a great description, but many cats, and I would actually argue that most of the cats that I see with obstructions don't fit that perfect description. That I might not see the stone, I might not see the obstruction, but I'm seeing some degree of pelvic dilation, proximal ureteral dilation, and clinically I'm coming to that diagnosis of them being obstructed. So that's an important finding, that you can have very, very tiny pelvic dilation and this still could be an obstructed kidney. Probably more likely to be partial than complete, but we don't know why some kidneys only will stay at 2 or 3 millimeters and then they'll rupture prior to going up to 12 or 15 millimeters. So we're not exactly sure why that's the case. Some people have hypothesized that maybe these are kidneys that have more scar tissue in them and maybe that's preventing them from becoming more dilated, but that's just a theory. Nobody really knows that for sure. So in those cases, if we're really trying to confirm if they are obstructed, you probably have to go with a pyelogram. And we published a retrospective analysis of pyelography showing that it was very safe, very highly useful. 94% of patients had a diagnosis following it. There was only one cat that potentially had a major complication. There was rupture of the kidney when we went to surgery. That rupture of the kidney occurred at the site opposite where we did the pyelogram, and there was already retroperitoneal fusion when we did the pyelogram. So the kidney was already ruptured before we poked it, but we couldn't say it wasn't us, so that we included it as a major complication. So very safe. This is all percutaneous ultrasound guided. That would be the way that I would confirm it. But when I have a high clinical intuition, I'm doing this confirmation in the OR. I'm doing it intra-op so that I've already had the needle into the kidney. I've confirmed it with my pyelogram. Then my next step is to pass my wire and continue with subplacement rather than doing it percutaneously. Considering an IV pyelogram, whether that's with fluoro or whether that's with CT, is really not a good choice. If the kidney is obstructed, its GFR is going to be very poor. There's going to be very poor contrast uptake when you give contrast intravenously into that renal pelvis. So many times those studies will be non-diagnostic because of poor contrast uptake. You also don't necessarily want to give a nephrotoxic contrast agent in this situation where when you give it post-nephron, when you inject it into the pelvis, you don't really have to worry about the effects of that contrast. And then lastly, I think our clinical intuition tells us a lot. You know, these cats are typically going to have, they could have progressive pelvic dilation throughout the course of their hospitalization. They might have marked azotemia with maybe little to no clinical signs, that they feel pretty darn good despite the fact that they have a creatinine of 15. To me, I only really see cats look that way when they have an obstruction or whether they have a Lilly toxicity. But these cats can definitely feel super sick. They can be hyperkalemic. They can be really variable. But if I do see these cats happy and healthy, it certainly makes me a bit concerned that that would be the that could be an obstructed patient that we're seeing. Larry brings up the concept of, you know, prior to ultrasound being readily available, when there's an acute obstruction, it might take 5 days or so before you're seeing that progressive dilation, especially when it gets to the ureter. And that's true, that you need time to allow everything to become dilated. So it could be that maybe it's just too early that you're not seeing evidence of the obstruction. So those are some things that I'm looking at when I'm trying to evaluate whether they have pyelo or whether they have an obstruction, which is very commonly the situation that we're in. A paper we presented at Renal Week, and it's currently in review. We looked at urine cytology and urine culture, and for cats that are isostenuric, if your cytology does not have bacteria present, we found that the absence of bacteria had a 92% negative predictive value in identifying a positive culture, meaning that there was only an 8% chance or likelihood that your patient would have a positive culture if they had no bacteria seen on their urinalysis. So that's our data. Like I said, this is still undergoing peer review at the moment. This is actually the pyelogram we did on the kidney that was on the right from a couple slides ago, the pelvis that was just about 3 millimeters or so in diameter. This is ultrasound guided. This is not intra-op. This is percutaneous. And you can see that we have dilation of the renal pelvis, and we have that proximal ureter that is dilated, and then it makes this really quick taper, and then you see this thread of the ureter beyond it. So this patient, we were highly suspicious that they had a stricture that was there. We went again and looked 15 minutes later, and we found that the bulk of all of that contrast was still sitting in the kidney, that nothing was flowing down. And the time frame has been reported that the contrast should really immediately enter the bladder after you inject it into the pelvis. So this was consistent with obstruction, and we did send that cat for a sub, and it had improvement in its mild azotemia that was present. So the pyelography was shown intra-op to be very effective in identifying the cause that's there. One paper showed 80% of cats had a calculus or a stricture, probably about the same from Allison's paper. I think this was their paper looking at subs. And looking at our paper that did the percutaneous approach showed that the vast majority of these patients had a diagnosis. The majority of them were obstructed, either complete or partial. But we did have about 20% of cats with what we call a functional obstruction, that we had flow of the contrast to the bladder rather quickly, within about 5 minutes, but it just never left the kidney as well too. And we didn't know if these were cases that might have just had significant ureteritis or what that could have been. Some of those patients did go and have subs placed and have improvement in their azotemia, but I don't know if that's really well understood what those patients are having, but that's a category that we kind of came up with as we were evaluating all of those studies that we had done. One thing I want to point out is when we're doing pyelograms, the way that most people do it is you'll put the needle into the renal pelvis, you'll aspirate some volume, and you usually give maybe half or maybe up to that volume back with your contrast. And if we just think for a second, if the normal urine output's 2 mils per kg per hour, and we have a 5 kilogram cat, then that 5 kilogram cat will be making 0.0028 mils of urine per second, which divided per kidney is 0.0014 mils per second, or over a 5-second push, that kidney will make 0.007 mils. Which, when we think about the speed at which we are injecting and when we're doing our pyelograms, I am absolutely injecting more than less than 0.01 mils in my 5-second push, which means that could I be pushing a volume that's fast enough that could overcome some partial obstructions? I think I definitely could generate enough supraphysiologic pressure that, like that pyelogram I showed, we were able to get some contrast to get through that stricture and make its way down. But that might not be what's happening under normal circumstances, because we're pushing the contrast so much faster than what the kidney is making urine. Even if you say that this is a polyuric patient and they're making 4 mils per kg per hour, heck, even 10 mils per kg per hour, they're still not making, 3 mils per 5 seconds or something along the lines of what we might end up flushing. So I just want to introduce that concept, because I think that's not something that we always necessarily pay attention to when we're doing our pyelograms, of just the ability to overcome some obstruction by the amount of pressure that we're putting forward. So that brings me up to this concept of, could chronic obstruction be what we're seeing in some of these cats with CKD, because there's so much overlap? We already looked at this figure on the left, this figure on the right. is actually from a paper that Jessica Quimby had done, and very similar, looked at the pelvic width in normal cats, those with CKD, those with pyelo, and those with obstruction. And interestingly, she didn't find that there was a difference between the obstructed cats and pyelo, but obstructed cats did have a wider pelvis than those with CKD. But I do worry that these studies are very challenging because both these studies are retrospective. The diagnosis of CKD was based upon clinical intuition. And when you have a kidney that looks like this, is this an obstructed kidney or is this just a kidney with chronic kidney disease? Personally, when I look at this kidney, to me, this kidney screams that it's obstructed. I have extremely high suspicion that this kidney is obstructed based upon the magnitude of pelvic dilation that's there, the blunting of the diverticuli. But this is actually from Jessica's manuscript that was reported as being a kidney that has just chronic kidney disease because there was no progression in the azotemia over time. My point is that unless we actually do some type of investigation, unless we do a pyelogram or some type of confirmatory step, looking at this kidney and saying, well, there's no progression in azotemia, I don't think is actually enough to say that it's not obstructed and is consistent with CKD. I have high reservations that this kidney could in fact be obstructed. So does that mean we need to be doing pyelograms on every kidney? I'm not necessarily saying that, but I do think that the data we have out is biased because retrospectively, if they never did a pyelogram, you're probably going to call that patient non-obstructed, but you haven't definitively proven that it is in fact non-obstructed. And I think this kidney is a good example of that scenario. Okay, that was all I wanted to bring up about obstruction. Any comments or questions or thoughts on that before we kind of move on and talk a bit more about what we see specifically now with what's reported with CKD and ultrasound? All right, well, I'll continue to pay attention to the chat, but we're going to go ahead and move forward. So what we will, so here's what's been reported for chronic kidney disease. This comes from just a couple of years ago, looking at B mode and Doppler ultrasound. And what's been shown is that typically we'll see as the cats develop CKD that there's increased echogenicity of the cortex. The cortex becomes more hyperechoic, and that's likely because there could be fibrosis or scar tissue that's accumulating within. But they did report that it also can be still normal appearing, but the majority of cats with CKD did have increased echogenicity. There have been papers that have looked at what was considered the mean gray value, so a measurement of how echogenic the cortex was. And this first study was actually in kidneys that were removed, so this is an in vitro study. And they looked as there was increased tubular degeneration, the kidneys became more hyperechoic, and as there was more inflammation, the kidneys also became more hyperechoic. And they were able to determine a specific cutoff value of the measurement of the echogenicity, and determined it had about an 80% sensitivity, 55% specificity for detecting disease versus normal kidneys. The same group then repeated it using actually doing ultrasounds in live patients rather than kidneys that were removed. And they continued to see that as the kidneys became, there's more tubular degeneration, the kidneys generally became more hyperechoic, but really only towards the highest score. When there was mild and moderate tubular degeneration, they were fairly equivalent to when there was none. And as there was more inflammation, there was somewhat of a trend, but it was less clear than when you had the kidneys that were separated by themselves as a way to identify what could be some of the underlying causes of the hyper echogenicity that you're seeing. Oh, let me go back one. Another finding that was reported in this paper is that you could see decreased corticomedullary distinction, that hyperechoic cortex to hypoechoic medulla, that line between became a bit blurred. And it was reported that this, obviously being quite a subjective finding, was there in about 25% of patients with stage 1 CKD and up to about 3/4 of patients with stage 4 CKD. Another paper looked at what is considered the medullary rim sign, which is this hyperechoic line in the outer medulla. These top 3 images are what's considered a thin band. Probably B and C, you can see it easier, but that's a thin band. It measures less than 2.5 millimeters. Images D, E, and F are considered a thick band, where the band is more than 2.5 millimeters. And what they found was the cats who had this thick medullary rim was more associated with them having azotemia, or oddly enough, a lot of cats with FIP would also have kidneys that would look like that as well too. So the thick medullary rim sign is another feature that can be seen in cats with CKD. And then I think this might be the last feature that's been reported, is that the kidneys become shorter. Their sagittal length decreases. And the frequency of cats having a short kidney or a small kidney is increased with IRIS stage, so much that we have about 3/4 of IRIS stage 3 and 4 who will have a shortened kidney, and about half of those cats are unilateral. In earlier stages CKD, most of those cats actually only had one of their 2 kidneys that were shortened in length. The other one tended to be normal. And that makes sense. You know, if the other kidney is functionally normal, if it's structurally normal, then their GFR potentially might be better preserved, and their stage of kidney disease might be lower than those that are having bilateral disease that are there. Okay, infarcts have been reported, and certainly something we see chronically in, with chronic kidney disease. This is probably the largest paper that has been published on infarcts, and I frankly don't find it exceptionally useful. They did have about 309 cats that were diagnosed with an infarct, either through ultrasound or necropsy. And they reported that if cats had an infarct, they were 4.5 times more likely to have hypertrophic cardiomyopathy, and more than 8 times more likely to have a distal or limb arterial thromboembolism. And so I hear a lot of people say, oh, we saw a renal infarct on ultrasound, we've got to do an echo now as the next step. They didn't actually report the prevalence of HCM in any of those patients, whether those who had infarcts or those that didn't. So I don't know what that 4.5-fold increased risk represents. Is it going from a 1% prevalence to a 4% prevalence, or is it going from a 10% prevalence to a 45% prevalence? I don't know, because they don't give us that data, and that's the same thing for the risk for the distal limb ATEs. And we also don't know what percent of those cats had the infarct seen just on ultrasound. So I think,
JD.
Yeah.
I have a question. I don't know how to do this in this kind of audience, but I'm just curious how many people. So for the longest time, when I would have an animal, the cat that would have an infarct on ultrasound, I would send it to cardiology. And I ended up stopping because I just didn't find an association with the cats that I was sending with an infarct with cardiology saying they had hypertrophic cardiomyopathy. And I wonder if looking at pro-BNP would be a better way, or I just want to, since you're bringing up the study, if there was a way to get an idea from the group how many people actually find heart disease in their cats with infarcts.
Yeah, I think that's a good question. I very similar to you, Shelley. I had initially maybe started sending some cats, but then I was kind of underwhelmed with what I was finding, and I don't choose to send cats to get the $500-700 cardiac screen based upon the infarct alone anymore, because it often comes up empty-handed, and that's a big chunk of change to kind of go down that wild goose chase. But certainly I'd love to hear what other people are considering.
Our cardiologists are a little bit sort of dismissive of this paper because they feel like there were no card-carrying cardiologists involved with it and making the distinction. And certainly when you're making that call of hypertrophy, it is a very grey area when you're looking for just very small changes in thickness.
Yeah, that's a really good point, Henny. Yeah, I think there are a couple notes that some people are sending to me in the chat that they're not sending cats to get echoes, and it's interesting because I think you see that what their paper reports, and it sounds over, it has some grip to it, that 4.5 times increased risk for HCM. That's something I should follow up, but that's the sexy statistic that the news outlets always report about studies, that using omeprazole increases your risk of kidney disease by 30%, and everyone freaks out, but it takes it from like a 1.2% risk to the general public to like a 1.4% risk, which is not nearly as sexy as when you say just the relative risk statistics. And I feel like that's what is kind of reported here. So personally, I don't tend to follow this up with an echocardiogram based upon this study and the few that have had not really substantial connections. Granted, small number, but I also don't think that I'm all of a sudden losing all of these CKD cats to ATEs or HCM. I certainly think that HCM is more prevalent, but in cats, you're just going to see that anyways. But I can't think of a single CKD cat that I've had who's ended up developing a distal or a limb thromboembolism. It may be just those cats that are hyperechoic, sure, are throwing, that are hypercoagulable, that are throwing clots to their limbs, are going to throw an infarct to their kidney as well, too. And one thing, there is a lot of chats, but a lot of the chats are just going to the organizers. So if you want to make some comments to everybody, just make sure underneath where you type your message, make sure it says to all, the entire audience. That way everybody can read your comments, and you can discuss back and forth, which would be great. Obviously, if you want to send something just to me, then that's great. There's no option to do it to everybody. That's weird. Okay, well, I'm sorry. I don't know why that's not an option. I don't know if Larry knows how to send something to everybody. I'll keep going just so we don't don't run over time. Sorry about that.
You should be able to send to the entire audience. I see it on mine. It's the first, should be the first click.
Yeah, I think maybe it's just the organizers who have that. Everybody else doesn't. So sorry about that. I will just keep reading the chats, and if you want to send me something privately that is only for me and not for anybody, just let me know so I don't read your dirty laundry to the group. So sorry about that, folks. Okay. And then lastly, I'm not going to get into it because there's so much information. It's an entirely separate discussion, but there has been a number of papers that have looked at contrast enhanced ultrasound. And here we have a CKD kidney on the left, a healthy kidney on the right, where they're using ultrasound contrast material, looking to see the different phases of the cortex becoming filled with the contrast material, then the medulla and the washout phase. And it has been reported that cats with CKD have a delayed filling of their cortex, and it tends to be not quite as severe, but their medulla tends to fill with, and the contrast accumulates faster to a larger degree. So there is some data, and again, I'm not going into it because there's lots of papers, but I just wanted to throw that out there. I personally don't do this. I've never done it, actually. I can't even say routinely. I've never performed this as a way to diagnose CKD or to evaluate it. I just wanted to kind of poll the audience and see if that's something that people were doing or if it was something done on a case-by-case basis. It's not something that's ever been a common feature of any of the practices that I've been in. Similarly, there's also reports of using renal resistive index, which is taking the peak velocity and the end diastolic velocity of the blood flow within the kidney and developing this renal resistance index, which was reported to have 100% sensitivity and specificity for identifying chronic kidney disease, and it was found to not be correlating to those cats who were hypertensive. So it is something that is out there again, but not something that I personally am using. I think I would imagine most people are probably in that same situation. But again, curious to hear if anybody uses this routinely as part of the way that they're investigating their kidneys overall. I referenced 2 papers here that talk about AKI. I'm not really going to get into it other than saying that there's no ultrasound finding that was seen with to be associated with survival. The more ultrasound abnormalities that were there, the worse they had done, but that is a loose association. But just wanted to give those references that that's out there. Okay, finally, now, a good 40 minutes in to talk about the papers that we were discussing. And that was kind of my goal. Like I didn't think these papers were so amazing that we needed to spend the entire time really digging into them, but I wanted to go through them a little bit more in this context of just talking about ultrasounds of the kidneys in general. So this first one was from 2018 from Lamb and colleagues looking at ultrasound findings of cats that were azotemic and not. And it was a retrospective case control study, went over about a 6-year time period. They had, depending on what blood machine they were using to measure creatinine, it had a creatinine, I'm going to continue with US units, that was greater than 2 or 1.6 milligrams per deciliter. And there were 6 different radiologists that were doing the scans during that time. This is just a table of what they were actually looking at in terms of the measurements of the kidneys and what to look for. And they ended up having about 238 and 270 non-azotemic cats that was enrolled in the study. You can see that the azotemic cats are older, and that's statistically significant. They are thinner as well too. So whether or not that might play a role, since the control group is not age matched, which age could be a factor as we develop more scar tissue as part of the aging process. They did find that the length of kidneys was not different between those cats with azotemia and those cats that weren't, but they did tend to have a more dilated renal pelvis compared to the non-azotemic cats. What was an interesting finding is that based on the initial report, 42% of cats with azotemia had small kidneys and 34% had enlarged kidneys. And let me say that they did not break it down whether these were cats with AKI or CKD. They just had to be azotemic. They didn't differentiate that. So you're going to see both here. But when they used the non-azotemic cats to generate their reference range, so they took their average and the 2 standard deviations above and below, actually only 16% of the azotemic cats had small kidneys and 6% had large kidneys. And they had suggested that there's probably some bias from the radiologist knowing the kidney values or the report or the history that led them to subjectively say that these are small or large, even though that's an objective measurement. That was much more frequent than what was done when they actually used the reference range that was kind of established internally. This is just a big table of all their findings, and it's quite busy, and we're certainly not going to go through it, but you can, really the reason I wanted to point it out is just look at the frequency of ultrasound findings in the non-azotemic population. So most things, if they're present, are probably there in, I think 11% of cats was the highest of any particular feature, and that was having a hyperechoic cortex, which is, again, a very subjective thing. 11% of cats had it, but otherwise these findings individually were present in less than 10% of cats in general. But, looking at all azotemic cats, looking at the entire population of non-azotemic cats, the majority of them would have at least one of these findings as you were moving forward to say, yes, this is something that is not 100% normal overall. Hattie also points out that using the creatinine greater than the 1.6 or 140 millimoles is a problem with the study because it's not necessarily a well-validated machine that they are performing the blood gas. I think it's just a blood gas bedside machine that might not be well validated for measurements of creatinine. And I think that's certainly true. We have a blood gas machine here. It actually doesn't contain creatinine. It's just the blood gas and the electrolyte. So maybe there are some problems with just the way that these cats were enrolled based upon their initial screening test as well too. So they found that 95% of azotemic cats, so almost all, had some type of abnormalities, but so did 50% of those non-azotemic cats. So it's going to be a common thing that we're going to see. These cats have abnormalities. And what is an interesting conundrum is that ultrasound is recommended to help investigate the cause of CKD. So once we've established it, we recommend using ultrasound to figure out why they might have it, which is reasonable. But it's not recommended as a screening test for CKD because many non-azotemic cats, as shown in this paper, will have abnormal findings. And that brings up questions because I've gotten this question from other veterinarians who have asked me when they're trying to define what a stage 1 CKD patient is. And I do think it's actually a little confusing in the way that IRIS states it. So for IRIS stage 1, it says staging is undertaken following the diagnosis of CKD. So you need to diagnose the CKD before you then determine what stage they are. But stage 1 are patients with normal kidney function, normal creatinine, normal SDMA. And in fact, one of the criteria could be abnormal renal palpation or imaging findings. So does that make the scenario that these 50% of non-azotemic cats that have abnormal renal imaging findings, by this definition, does that mean that they have stage 1 CKD? But then IRIS also says, well, you should only stage them after you have established the diagnosis, which for the non-azotemic patients, we're essentially looking at this, which means that half of this normal, or let me say non-azotemic patient population in the study would be considered to have stage 1 disease. And that might be okay, and that might be fair just to continue to have good vigilance about the kidneys, but does become a bit of a challenge when we haven't looked to see of these patients that are non-azotemic that have these abnormal findings, what % of those will actually go on to develop progressive kidney disease, that they will have progressive loss of kidney function. And that's actually a study that we're doing here using retrospective data in cats that have had serial analyses to be able to see if we can find some of these features that can maybe predict cats that are more likely to become azotemic in the future. Otherwise, it's kind of this circular argument of they're abnormal, which is a definition of stage 1 disease to establish them having that diagnosis. So it's something I feel like it's not really completely understood, or I think it creates confusion because frankly, I can see it, that you can be confused about how you confirm CKD in these non-azotemic animals when half of them are going to have abnormal kidney findings. We haven't necessarily proven that it is those abnormal findings are predictive of them going on to develop abnormal kidney function.
Yeah,
And Hattie, yeah, go ahead, Larry.
I just might state that the staging of stage 1 CKD doesn't infer that these animals are going to progress. It merely suggests that there are kidney abnormalities that are present, that are detectable, to indicate that there is or has been some kidney disease in the animal, but the animal is in a non-azotemic state at that point. So that's what it was intended to do, is to try to help recognition and some definition of animals that have some clinical evidence of damage or disease in their kidney, but they still remain in a non-azotemic chemistry status.
Yeah, and I think that's good information to have. And Bianca brings up the question of, if the definition of CKD is abnormal function or structure, doesn't it argue that these patients have CKD anyways? And certainly if their kidneys are abnormally structured, then sure it would. Hattie suggests that she takes it as something being more convincing on ultrasound, like a Persian who might have evidence of multiple cysts. So you're concerned that they might have polycystic kidney disease. And we could probably continue the rest of the discussion about this topic in itself, because I think it is a bit questionable. And there's probably no harm in maybe over identifying patients as having stage 1 disease, except for the fact that owners get very worried, they get upset. Referring veterinarians, primary care veterinarians are now wondering what to do with that information, what to do with that diagnosis. Do we feed them KD? What do we do? And it creates some challenges. So I agree, it's not normal. We should know that it's not normal. And I think it's the problem with what to do is the follow-up, which is kind of the big question that I hear from a lot of vets wondering what to do with that information.
Well, that might be interesting for another journal club, because there are a couple articles out now that look at early or at-risk cats. And I guess to me, the value of knowing they're stage 1 is that you know they're at risk, so you're careful with them. Yeah. And there are some studies now that have looked at changing their diet, and it's very subtle evidence that it is that there is a benefit in that, even when there's early disease.
Yeah, I agree. Anybody who wants to tackle those articles, I will sign you up on the schedule. Shelley, I'll pencil you in. But certainly this paper pointed out that, that there's a lot of subjectivity when it comes to making measurements, and that's something that I think we all recognize. I'm just going to keep going forward because I don't want to take up too much time over our 1 hour. Finally, this is the paper that I wanted to talk about, which, long story short, I don't think is a super amazing manuscript, and that's why I kind of spent more time just discussing ultrasound in general and reviewing some of the literature than focusing on this. But the aim of the study was to look at renal cortical and medullary thickness, because in people that correlates better with renal function than kidney length. And so they did look at length, but they were looking at cortical medullary thickness and the corticomedullary ratio in cats with CKD compared to normal. This was a retrospective, a case selection that was based upon cats that had a diagnosis of CKD, which was fair. I thought, excluding cats that had cysts from their kidneys. I'm guessing they did that because maybe they thought it was going to expand the cortical length, which they don't explain, but if that's the reason, that's fair. They grouped them according to iris stages. They did have 28 healthy cats prospectively enrolled as controls, which I have a bit of a problem with. This is how they measured things. They looked at the length on a sagittal view, and then they looked at the cortical and medullary length. They used the arcuate arteries as their point of differentiation between the cortex and the medulla. For CKD animals, they would, if there were multiple measurements that one was a little bit shorter than the other, they would measure both and they would take the average, and they were comparing between the two. Stats I thought were fine. I have a problem with I'll get to it in a second. Sorry, I know I'm going a little bit fast, but we are running quickly out of time. So they did only ended up enrolling 19 of their healthy controls. They don't say why out of the 28, they only ended up with 19. And they identified 30 cats with CKD, and fairly equal across the 4 iris stages, but they were low numbers. They grouped them into 2 groups. Group 1, which would be iris stages 1 and 2, and group 2, that was 3 and 4. I thought pretty low numbers for a 6-year time frame for cats that were going to fit their inclusion and exclusion criteria. Breaking it down to the stage 1 and 2 versus 3 and 4 in controls, you can see that their control group was very young compared to their CKD group. Average median age was, or this is probably their mean age of 4 years versus 11 years. To me, I think that is, if you have the retrospective data and you know your patient population, you can try to age match it and as best as you can, because that could skew what you're looking at. When these older cats might have abnormally shaped kidneys because they are 11 years old versus 2 years old, but still potentially have normal kidney function. So I thought that they could have done a better job with that. Obviously, the azotemic cats are azotemic, so no big surprise there. One thing they looked at, they had 2 people review the images, and one was a radiologist, one was, I think, the equivalent of a radiology resident. They describe it as a radiology graduate student. And they're looking at how well they had intra-observer and inter-observer agreement between measurements. And I'll just say that, obviously we want this number to be as close to 1 as possible, but there are some things like the length of the medulla, which did not correlate really well between observers. Even amongst the same person measuring it again, we have 70% and above for the agreement rate, but some things are in the 50s, even down to 34.34 for the left kidney corticomedullary distinction. What do I take from all of this? That it's subjective. Even when you're trying to take objective measurements, that there's some subjectivity to it. What image do you use? Where exactly do you put your cursor when you're making your measurements, which is challenging if that is what we're basing a lot of this upon. If we're going to call a stage 1 patient maybe having a small kidney, can we trust that that small kidney is something that's observed repeatedly with multiple users? I think we can be mostly confident in that based upon this table, but I don't know if I'm extremely confident in that paper. And that the same is true looking at our cats with chronic kidney disease. That first table was the normal cats. You can see some things don't correlate very well, that there wasn't very strong agreement between observers with some of these variables. Maybe that's because one is a not very well-trained individual. We don't know that, but that's the data and that's what they choose to evaluate here. So they talk about the dimensions, and frankly, I don't take a lot out of what's more important, left kidney versus right kidney. I think they probably should have done a better job, like the way Jessica had organized her table, where they looked at the maximal length between when she was looking at the renal pelvic diameters, because we know that cats can have unilateral disease that could be more affected. So maybe just having the either the smallest measurement or the largest measurement, because some of these cats are going to have their left kidney that could be more disease, and some cats are going to have their right kidney more disease. And when you put everything together, it doesn't actually, I think, stand out to me to be very dramatic findings overall. You can see that certainly there were statistical differences that were there. I frankly just don't take a lot from it when we really start separating one kidney to the next. I'm not going to use a single kidney that performs better statistically as how I'm going to diagnose CKD in my patients. They did receiver operating curve analysis, and they did say that there was a pretty high ROC for the left and right cortical thickness. So if we just kind of combine that, more than 0.9 for the cortical thickness as the ability to predict a disease kidney or not. but this removes the staging. This is not now looking at groups 1 and group 2. This is just CKD or not. So, okay, if the cortical thickness becomes thin, they're more likely to have CKD than being normal, but it doesn't actually help us with those iris stages and be able to predict what that patient might potentially fall in. And they found that the thickness that was best was about 4.6 millimeters, 4.7 on one kidney, 4.5 on the right. So that was their cutoff points for being what could identify a diseased kidney from a healthy kidney. So they actually found that the cortical thickness was associated with renal function, and it performed better than kidney length for detecting CKD, which I'll be honest, we in my hospital here, we do measure length on everybody, but we're not routinely measuring cortical thickness. So, you know, is that something that we could do and could start doing? Sure, we have the images saved. It's something that we could easily do. I'm still kind of questioning exactly the utility that we'll get from it, but it's certainly something that we can add. They do say that the measurement of the thickness had satisfactory to excellent agreement, which I would love it if it was excellent agreement, but I'm not really that thrilled with just having satisfactory agreement between observers. So that is certainly a problem that I think this paper again points out, is that there could be biases, and depending on who's doing the measurements, or even potentially the same person doing measurements again. And then lastly, some of my critiques, you know, they talk about the reciprocal creatinine being their indicator of GFR. I think it's fine that they didn't do GFR testing. I don't think that was necessary. They do I very well reference Natalie's paper that showed that in cats, the reciprocal creatinine only accounts for 43% of the variability seen in GFR. So when we're actually trying to use GFR for research purposes, you have to measure it. We can't use creatinine or its inverse as a metric for it because there's too much variability. I thought it was a little frustrating that in some analyses, they just ignored their idea of trying to look at stages. They don't actually define, when they talk about normal versus just CKD, what they use for those analyses that was just looking at CKD or normal. I imagine it would be stage 1 or above, but they don't actually state it. I think they gave way too much data by looking at left and right kidneys individually, and they should have just looked at maximum and minimum of both kidneys combined. They could have done a better job with their control group. And then the other subjective characteristics, like infarcts, the shape, if there are cysts that were less than 5 millimeters, any of those things would have been great information to have as well. And those were just not included in the manuscript, and I would have loved to have seen that. So my take-home points is that length might not be as reliable as cortical thickness for CKD. Cats with normal kidney function often have abnormal looking kidneys. I care about the function more than I care about how they look, but certainly that's good information to have. And then I bring up kind of my soapbox of, you know, are we missing some of these cats of having chronic obstruction that we're diagnosing as just CKD because they have static disease? That doesn't mean that they don't have a static partial obstruction that's not going to become progressive because they have scar tissue that's accumulated. And I think that was all that I had on that discussion. So I know it was a bit of a mixed bag, not as deep into the literature as some of the other ones, but certainly I just wanted to take a more kind of broad description, talk about some journal club, some manuscripts that are out there and just how we approach ultrasound in cats. Anyways, any questions, thoughts, comments, anything that people would like to bring up? I know we're a couple minutes over, but certainly we can hang out for a few more minutes if people have any other points they'd like to make or questions they'd like to raise.
If somebody wants to do a journal club on what to do with the partial obstruction cats, that would be super.
Yeah, the wealth of publications that have been out there, easy to pull and report on for sure. And Dr. Vincent, who was kind enough just to speak up, she'll be presenting at the next session, which will be in 2 weeks. She'll be reviewing the JVIM article that evaluated pyelonephritis in dogs, a retrospective. I think this was a 3-hospital multi-center retrospective analysis. So we'll be reviewing that. I will send the paper out to everybody. And again, thanks to everyone who came. We'll try to get the problems with registration and things like that figured out before the next one. I'm thrilled that we have more than 200 people that are interested in attending these rounds. You know, we clearly don't have as many who actually show up, but you know, that's pretty darn good still throughout the entire world of people who come to it. So I'd love to try to get as many people as possible involved and participating. I think it's a great forum for us to connect and share and collaborate. So hopefully we'll get that all figured out before the next one. But thanks everybody for attending. Thanks to a bunch of people who have signed up so that you don't have to hear me talk again and again. That's boring for everybody. So thanks for signing up for some presentations over the next couple sessions to those who have. I really appreciate it. Let me know if you have any questions or you'd like to sign up and you can't do it. Please just shoot me an email. And I hope everybody has a wonderful weekend and look forward to seeing everybody around in 2 weeks.
Thank you.
Thank you.
Anytime.
Thanks,
All right.
Judy.
Of course.